My name is Professor Chris Andrews. I'm a gastroenterologist at the University of Calgary in Canada, and I specialize in gut motility disorders. I'm also the Chief Medical Officer of Alimetry. I've been using Alimetry in my practice for about the last 2 years. We've found that it adds a lot of value to our diagnostic workup of patients with chronic nausea and vomiting and severe functional dyspepsia. When we deal with gastroduodenal disorders, there's a lot of uncertainty. I find that Alimetry helps us cut to the chase a lot quicker. I'm using Gastric Alimetry more and more for my patients with chronic nausea and vomiting or dyspeptic symptoms. The standard of care is still a gastroscopy to rule out a gastric outlet obstruction, but after that, I'm finding it's by far the next best test for patients who have persistent symptoms or very severe symptoms. In addition to giving me a lot more clinical certainty, it's also allowed me to direct therapy in many cases. The Alimetry does seem to help in patients who we know have severe neuromuscular disorders, because even sometimes years after the onset of symptoms, they may still not have a really solid diagnosis, or a specialist has not been able to pull the trigger and say, you actually have a myopathy or a neuropathy or a degenerative neuromuscular disorder of your stomach, the gastroparesis. Alimetry is also very helpful in patients with centrally mediated disorders or visceral hypersensitivity. As a motility specialist, we definitely see the more severe end of the spectrum, and that would include places where the Rome criteria for dyspepsia break down. The beauty of Alimetry is that if a test is normal, you can be quite certain that this is a central problem and not a stomach one. Alimetry is easy to talk to patients about. I essentially talk or explain it like it's like an ECG for the stomach. So it measures the electrical activity. There's a lot of information we can get from that activity in the stomach. It's non-invasive. There's no risk with it. And in our clinic, we can actually get it fairly quickly. So based on all those things, it's an easy sell to get patients to agree to have one. Alimetry is very easy to implement in almost any practice. We have been able to have used staff that were otherwise not being used in the clinic or in the endoscopy unit. We also find that it's not a lot of technology to bring in. It's very convenient and portable. And so it doesn't require virtually any infrastructure at all, other than a comfortable chair. In terms of reporting and understanding the reports, it's really quite intuitive and straightforward. In our clinic, as many gastroenterologists do, we have an infusion center. And so the same recliner chairs can be used to do an Alimetry test that we use for biological infusions. So we've been really able to harness the use of doing this test in-house in our own infusion chairs, which allows us to not only get it done very quickly, get it done correctly, and also you can occasionally visit the patient while they're having the test done. Alimetry is more than a niche test. In my practice, it's been a game changer. It's really allowed us to move forward on clarifying who has gastroparesis and who has dyspepsia. And in my practice, it's actually changed the paradigm of how we go about that, to the point where I very rarely use gastric emptying scintigraphy anymore. And I'm certain that moving forward, that this will become the way that people diagnose these disorders. And that will open so many benefits, not only for patients, but also for drug development and also for moving the field forward.